Yeah, we're on. I'd like to welcome everyone and thank you for coming to today's Discovery Cafe session on reimagining disease management. We have about 75 minutes today, including Q&As. If you've downloaded the app, please use that. It'll be transmitted right up here. And we have a very full schedule, so why don't we get underway? And it's my pleasure to introduce your moderator today, Sree Chaguturu, Chief Population Health Officer for Partners Healthcare and Assistant Professor of Medicine at Harvard Medical School.
Thank you so much for that kind introduction, and thank you so much for joining us for this panel on reimagining disease management. So we do have a great lineup of panelists here. I want to thank my panelists who have agreed to join us to discuss disease management, and I'm going to let them introduce themselves in a brief moment. And so just to orient you all on what the arc of the conversation will be, we really want to spend some time defining what is disease management, so we all have the same definitions as we start going down the path of reimagining what disease management is. Once we define what disease management is, we're going to start talking about what have been the opportunities, the failures of disease management in the past, and what are the opportunities in the future, specifically around AI and machine learning to really transform disease management. So we'll first start talking about the data and the data necessary, then we'll talk about the algorithms and how the algorithms can be improved. Then we're going to talk about patient engagement and provider engagement. And so that's the arc: data, algorithms, patients, providers. So I'm really excited about this panel. And so I'm going to now turn over to Erika. Erika, thank you for joining us. And if you could we're just going to go down the line and provide a little background about each of ourselves.
Thanks, Sree. Great to be here. And thank you guys for joining us. We hope it'll be a really interactive discussion. I'm Erika Pabo. I'm an internal medicine primary care doc by training and background. I practice at Brigham and Women's Hospital at one of our patient-centered medical homes. I've come at disease management from a variety of angles and hoping to bring that to the discussion today. I first came at it from the perspective of early-stage health technology companies trying to build tools for patients and providers to interact in a more meaningful way to help patients achieve their goals. I've also come at it from the provider perspective, both as a PCP, but also in my most recent role. Prior to my current one, I was helping run 15 primary care practices at Brigham and Women's Hospital, working alongside Sree in many initiatives in an environment where we were taking care of about 200,000 patients, where about 70% of those are in some sort of risk-based contract. And then about 6 months ago, I left and joined a Skunkworks innovation team on the payer side within Humana, trying to reimagine care for seniors. So now thinking about disease management from the payer's perspective. So great to be here.
Good afternoon. My name is Julian Harris. I have on the microphone, never mind. I too am a primary care physician trained here in Boston at the Brigham and Women's Hospital. I've spent my career I think in two major chapters. One in government, so I ran the Medicaid program here in Massachusetts, Mass Health, and we worked on the Health Information Exchange here in the state. We built Medicaid ACOs and also did the country's first Medicaid duals demonstration. And then a federal chapter leading the healthcare team in the Office of Management and Budget, which is sort of the finance policy and management oversight part of the Office of the President in DC. So oversaw CMS, so Medicare, Medicaid, the Innovation Centers and the Exchange, but also the NIH and FDA. And then the last 4 years I've been at Cigna, both in strategic operations, leading that across our US businesses, and then more recently, bringing together a family of provider and plan services businesses under the brand CareAllies. And we work both in population health with physician groups and health systems who are on their journey in value-based payment. And then we also do home-based primary care for complex populations in the Medicare and Medicaid program. I'm really excited to be here today.
Great, nice to be here as well. I'm Murray Brzezinski. My story started, I've been an entrepreneur in technology and data when it was called small data, and then big data, and then machine learning, and now the broad AI that we are talking about today. I got into healthcare about a dozen years ago and have been involved in co-founding and helping to lead 4 different startups in the digital health space, Conversa being the 4th, and I'm Chief Strategy Officer of Conversa. Conversa has developed an artificially intelligence-driven conversation platform. So it automates conversations between care teams and patients. The first goal of it is to truly engage the patient in their care on an ongoing, very frequent basis. And the second, equally or maybe even important goal, is to collect the patient's feedback, biometric readings, answers to questions, feedback about how they're feeling, this valuable data set that we really don't capture, and to risk assess every single response to determine one of three things: whether the patient is on track in their care journey, and then the system continues to motivate them to do what they've been doing, or they're off track, and we can, in an automated way, use some behavioral science technique or education to nudge them back on track. Or the third is to identify that they need to be escalated to speak to a scarce human intelligence, a care team member, and it gets them to that care team member at the right time, importantly, with the data to provide context for that intervention.
Great, and hi, Chandra Wah. So I briefly trained as an MD, so the day I left medical school, I went straight to business school. Over on the West Coast. I ended up at a consulting firm, McKinsey, for what I thought would be 2 years, turned out to be 15. Spent 8 years in the UK, amongst other things, ended up overseeing London's healthcare, so all of the hospitals, social care, primary care, and eventually made my way back to the US. And when we saw the convergence of new payment models, data becoming available in much bigger ways, being able to engage with patients with their mobile phones, and being able to bring analytical platforms from other industries, I decided to make the jump and start a company called Clarify. And the way to think about us is the same engineers that built Goldman's and JP Morgan's analytics platforms, so the platforms that take in the world's trading data as it comes in real time and across bonds, stocks, derivatives. When a pension fund manager, an individual logs in and says, here's what's in my account this minute, take that platform and bring it into healthcare. Now, interestingly, the work of predicting the value of a derivative, so farmer hedges against the weather hasn't happened yet, is uncannily similar to patient comes in with a set of characteristics, including social behavioral determinants. How is he or she likely to do in the journey moving forward? So if you feed that kind of a platform with a large data set, which could include CMS data, claims data, genomic data, et cetera, you end up with the ability to far better risk stratify and then look at the performance of institutions and physicians using the same wins above replacement types of metrics that the Boston Red Sox are more used to being known for, because you can look at the value created against the difficulty of the patients faced in the same way that you look at how does a batter do depending on the pitchers that they faced.
Thanks so much, and I hope now you share the enthusiasm that I have for this panel with their broad range of expertise from provider, payer, government, technology, from the front lines to the back support system. So I also want to encourage you all, on the application you have the opportunity to ask questions, and I want to make sure to intersperse your questions with the questions that we've talked about as a panel, so please do send your questions our way. But why don't we start with the first thing that we discussed, which is defining what is disease management. And Julian, I might turn to you first, just to define what is disease management, and as you're doing that, probably define what the different modalities of disease management are. And I want us to draw a sharp distinction between disease management and other forms of management like care management and utilization management. So
Sure.
I was wondering, Julian, if you could just help set the stage for us.
Great. So I drew the short straw on this one because one of the things that you quickly understand is that these are not perfectly discrete categories. So I'll say that as kind of a caveat going into it. But when I think about disease management, I think about how does an organization, whether that be a provider organization at a physician group or a health system level, or a health system, or a payer, think about managing a population of patients and with a specific focus on chronic conditions. So think about someone who has diabetes or who has heart disease. How do they think about leveraging data to think about sort of interventions in the aggregate? So we'll get to care management in a second, but not the discrete intervention for Mrs. Jones, but how do you think about an intervention for a broader population of patients? Think about leveraging risk stratification to both build programs that can target everyone, so primary, secondary, and tertiary prevention are all relevant in the context of disease management, but sort of targeting the intensity of a disease management program based on an evidence base around interventions sort of going up the severity pyramid. When I think about care management, I think more around how do you, for a patient who has multiple chronic conditions and potentially more complexity, how do you ensure that they have the right types of supports with transitions of care? How do you ensure that across multiple chronic conditions and potentially specialty types that their care is coordinated and in a sense make sure that the fragmented healthcare system is working for someone who has that kind of complexity? And then kind of the step beyond that in the context of case management, I think about someone who's really focused on a broader understanding of the patient's condition, including helping to address the social determinants. So thinking about housing, thinking about food, thinking about transportation and some of the broader supports. I think there's a lot of relevance in this conversation across kind of all three of those categories of leveraging more robust insights, leveraging artificial intelligence and other advanced analytic modalities. And when you think about kind of zooming back to disease management, although it's in some ways relevant across the three, from a modality perspective, we think about telephonic disease management. And I think that there's been quite a bit of research around the effectiveness, or in certain cases, lack thereof, of telephonic disease management programs, and yet they continue and people continue to pay for them. What I've seen is that when those programs are more targeted, there actually are ways to build telephonic programs that are impactful, but we have a sort of complex history to overcome and some stigma to some extent around telephonic disease management. When we think about in-person disease management, I think you're starting to kind of get to the fuzzy line between disease management and care management. But having that orientation around specific conditions, as I said at the outset, so what does it look like to start with your broad population and then think about what you might be building for your diabetics or your patients with heart disease, and thinking about how those interventions can be for the sort of most complex patients delivered in person, but again, getting to that fuzzy line potentially with care management as you get closer to that space. And the last piece, digital, is an area where I think there's just an enormous amount of opportunity, and I think we'll actually see much more impact from a digital approach to disease management than we saw with some of the earlier and now somewhat stigmatized approaches that were telephonic, and in part because we are able to not only leverage data to deliver digital modalities, but actually leverage data to collect or leverage advanced analytics to better utilize the data we're collecting from those digital tools. So not just pushing out information or pushing out interventions, but actually pulling in information and then having the rigor of a artificial intelligence approach to be able to look across claims data, electronic health record data, remote data, patient entered data, patient reported outcomes, and to be able to make sense out of that and transition it from information into insights and actions.
Thanks, Julian. And so that's really helpful. I hope now we all have an understanding of what is disease management, different modalities. I would just ask the panelists, do you have any friendly amendments or additions that you would want to add to the definition? Seeing none, we're going to proceed. So in terms of disease management, there's a lot of potential here, but we haven't actually recognized the full potential of disease management. And you can see from the nodding here on the panel that there's a profound agreement on this statement. And we also think that artificial intelligence can make a difference in improving disease management. So I was wondering if we could spend a little bit of time, and we're going to go deep into data and algorithms, patient engagement, provider engagement, but just at a higher level, I was wondering if you could just talk a little bit and share your thoughts on why disease management hasn't worked to date as much as we thought it would.
I think there are many. I think one piece is Julian provided a very eloquent and I think very good description of disease management, but it's complicated. It's not the language people actually living their lives think about themselves in. And so our interventions aren't necessarily meeting them where they are. It is the very rare patient who comes to me and says, I want to manage my COPD, or I want to manage my diabetes. People want to live their lives, and we've often had a very provider-centric view of disease management, provider broadly defined, whether it's the nurse providing the telephonic disease management intervention or a doc in their office. But I think not recognizing where patients are in their own journey, what it would actually take for them to change their behaviors. I think that would be one major piece. Another major piece, when I was on the IT side selling into provider organizations, a challenge was not integrating into physician or provider workflows. So you might have a sort of telephonic disease management or even digital intervention, feeding fabulous information and data into an abyss, into repository somewhere that doesn't sort of overlap with the physician or the provider's workflow when it actually needs to get bumped up to that level. So I think not having the right orientation around our patients and not having a meaningful way to integrate into other aspects of physician workflow would be two pieces that come to mind.
Yeah. If we look at an analogy from everyday life, which is in order to go from Boston to New York today, a lot of people would use Google Maps or Waze, and that would say, based on what we know of the traffic, here's the route you should take. But imagine that the GPS signal for that was tracking you or your car was imprecise to the degree that it didn't know which road to put you on. Right? That would not work. And essentially, with respect to disease management and care management, per Julian's definition, you have to have a precise enough understanding of the individual to ideally be able to match them to the most effective and efficient intervention. And one of the reasons that V1 of disease management, so healthways, et cetera, for which there was a lot of promise 15 years ago, and even today's interventions sometimes are seen to have, at best, diffuse ROI, is that when the pyramid is done of the tiering of the population into different risk categories in order to be matched to either care navigators, home nursing, phone calls, or you're just fine, those tierings are full of false positives, essentially. And so too many people get tiered, and then the interventions, therefore, end up having lots of folks who didn't need them, and those that needed them aren't tiered into the right tiers. And as a result of it, the ROI goes down. So although it's interesting, we didn't start there at Clarify. What we've noticed applying, in this case, machine learning to large data sets is risk stratification is, in fact, the patient-level GPS signal that we need in order to be able to enable higher ROI matching of patients to the right interventions.
Sean, that's a great analogy, and so it's actually, we wanted to make sure this panel wasn't deep on just disease management, but what is the specific role of artificial intelligence and machine learning in helping to create that GPS signal, if you will. Yeah. Sort of underlying your analogy is that we need to have good data, right? So I was wondering if we could talk a little bit about data and how you all are thinking about the role of having quote unquote good data for being able to develop what we'll talk about next is the algorithms. But I was wondering if one of you wanted to take that question.
Sure. Yeah. Yeah, I'll talk about it in two ways. One, and it piggybacks on what was already said about the failure of disease management in the past, I think, which is, how many people here have kids? I can't see with the lights. How many people here have or had parents? I want to get 100%. Okay. All right. So imagine if you were raising kids and you said, we'll check in once a year, and other than that, if you're not doing well, come see me. right? No one would ever dream of raising kids that way, yet that's what we do in the healthcare system, and that's what we do and have done in large part in disease management. So when things get acute, we deal with them. We have scheduled phone calls, scheduled visits that Julian talked about. I think what we need is a conversation. When you have a conversation, one, it's frequent. Two, it's two-way, right? And so it's not just about identifying, and it's very important to identify the risk stratification of patients, but once that's said, it's static. And so understanding the changes in risk stratification, who's a rising risk that was low risk, who's going from rising risk to high risk. And so one, I think collecting information through a conversation gets at a much richer tapestry of information on a more frequent basis. So that's one thing I would say about data as it relates to failure in disease management. The other is that historically disease management was based on largely what was available clinically. And we know now from a whole bunch of studies that if you look at premature death and health in general, clinical factors contribute maybe 10% to the outcome. We're learning that 10 to 30% of that outcome is due to genetics. That's still less than 50, right? So where's the other 70%? The other 70% is, by and large, behavior is about 40 of it, and roughly 30 of it is social determinants, which is a big bucket. And I think, actually, it's very difficult to separate those two. They're very related. But think of, almost 70% of the determinant as to whether or not somebody is going to be readmitted into a hospital, somebody's going to go from pre-chronic to chronic, is in that bucket. And we historically didn't have access to that bucket because that bucket is largely the purview of the patient. You need to be talking to the patient all the time to understand that the patient had access to transportation and now they don't have access. They had a professional caregiver, they no longer have that. They used to live on the first floor, now they live on the second floor. All of these, access to food, no longer have access to food. These are social determinants that require lots of investment and lots of policy changes to systemically change it and make it better, but to understand where a patient is on the risk strata and how that changes and when you need to intervene is all about talking to the patient. And behavior is even more in control of the patient, right? So being able to, all the chronic illnesses we're talking about are driven by food, tobacco, alcohol, exercise, and a couple of other factors. So being able to talk to patients, not just say, we've determined this is good for you, did you do it, right? It's sort of, why didn't you do it? And how do we get you to do it? And so that conversation, I think, dovetails nicely with the data that hasn't been collected, the 70% of this pie.
Yeah. So you're putting forward an interesting thesis that we don't have enough data to really create that GPS signal, if I will. But one of the questions I have as a follow-up to the panel is, so we talked about, we want data to as closely represent biology as possible. We're using clinical data, but we're not using these other data sources. But how much data do we actually need to actually improve the state of disease management? Do we need to collect all of this, or is there a smaller subset, and or is the data we have at hand just needs to be analyzed better, Julian?
I'm really glad you asked that question because I think we have to approach these conversations with an enormous amount of humility. We have a tremendous, before we get to advanced analytics, we have a tremendous amount of data today that we don't use, and we are going to have an increasing amount of access to other data sources. So, just kind of start foundationally. Payers have had access to claims data forever, and providers in certain cases have had years of access to electronic health record data. And I'd say just in those discrete cases, they are both suboptimized. Providers are not getting everything that they could from an EHR. Payers are not getting everything that they could from claims. Now think about a world where they're exchanging data. So the payers and providers both have access to each other's data. An enormous amount of opportunity, but still tremendous gaps before realizing the promise just there. Now we bring in social determinants data, or we bring in genomics data, et cetera. We bring in the data from remote monitoring devices that is actually kind of terrifying, because if someone has access to it, then are they responsible for it? So I think part of what excites me is not necessarily just getting more to put into the pot, although that's important, but also how do we think about getting from having access to a diversity of types of data, significant quantities of data, to the bridge to kind of actionable insights, and then not just stratifying the patients, but actually saying, how do we leverage advanced analytics to change treatment protocols, to change provider workflow, to change how we think about engaging with patients on the ground. That feels like the gap from where I sit.
So you're taking a fairly measured approach in terms of what we can do a lot with what we have, and incremental additions will unlock more value. Jean, what are your thoughts?
Yeah, here's what's possible today, right now. So it is possible to take Medicare's entire data set, identified, because that's what qualified entities are able to do. It is possible in a fully HIPAA compliant way to union that with over 100 million lives of claims, commercial claims data, and to decorate all of those lives with social determinants data. Okay. And it's possible to get that data at a month lag, if not less. Okay. So the stratification can be done on a monthly basis, and soon will be able to be done daily. Now, what is it that you can do in that context? Well, it's not just the initial stratification. If somebody loses their driver's license, if somebody loses a spouse, if somebody has a family member move more than 5 miles away, you can pick that up and indicate to a care navigator that there's a change in risk. And you can say why the risk changed, so that that's the intervention that somebody can take. That's doable right now. The other thing that's doable right now with that large a data set is to say, Dr. Smith, on a total cost of care basis, the metric you would get from Premier or Optum is that your total cost of care is $19,500, and that is the lowest that we observe in the Los Angeles area. Okay. You can now also say your case mix indicated that it should have cost $21,500 to take care of those patients. So you created $2,000 worth of value, and the reason you did that is your readmission rates are lower across most of your patients. That said, there's a specific cohort of patients, which are the 27, this is a real example, right? But 27 African American females over 75 years old with an income under $39,000 with diabetes. That's the population where for some reason your readmission rates are twice what they should be. Now, it's not causal, and anybody coming in saying and pretending that it is causal isn't being truthful about where statistics are today. But having said that, where there's smoke, there's sometimes fire. So what the clinician is then able to do is to say, look, okay, when these kinds of patients come in moving forward, I'm going to send them all to a pre-op clinic run by the anesthesiologist, where they're going to do a much deeper interview to see what factors might be addressed post-op to improve the readmission situation. And then we will track to see if we actually notice a difference moving forward. So to Julian's point, there's an enormous amount that can be done with what exists today. And then obviously if you can add genomics, et cetera, conversational data, then that only improves the ability not just to stratify up front, but then to monitor in real time. And if you come back to the Waze or Google Maps analogy, that's what you have to do, because at each node, which is every exit you go by, it's figuring out whether you need to turn off or not. And we have to get to the same real-time monitoring if we're really going to get the precision that we need around, by the way, what are well-known and good interventions. It's just that they're not matched specifically enough right now.
So this is great. So we can do a lot. There's a lot that could be done today, and there's a lot of incremental value that could be unlocked by aggregating the existing data sets, and the more we can add, it'll be exponentially more valuable. And so, Erika, this is a question for you, and then to open up to the panel. You know, as we think about the future of disease management, we're going to have to sit these companies and these technologies on top of these data assets. Somebody's got to aggregate this data. Do you believe that it's going to be the disease management companies that are going to do this, or they're going to be aggregators of data, and that the companies will have the opportunity to use that data?
So I think it's a great question, because I think any given company in this ecosystem has access to at least one, if not, as was just said, a tremendous number of data sets that they could then aggregate. I think the question is, if everyone has that or could have that available to them today, why aren't they using it? And I think one of the challenges, as with sort of every aspect of healthcare, is we are traditionally so siloed. And so when I think about the future of disease management and who will be able to take advantage of the data sets and analytics that are technically possible today and actually make use of them, I really look to organizations sitting at the intersection of payers and providers who are forward-looking enough to have a sort of deep technology stack that can take advantage of all of this. So people started to talk about sort of pay-vidor organizations, but I really think opportunities, or the places where there'll be the most opportunity, are where both the payer entity is fully capitated in some way, fully responsible for the outcome, meaning fully financially responsible for the outcomes of that patient population, coupled with the delivery system that has the range of clinical assets capable of achieving that outcome. And I think you'll see organizations like a payer that I now work for that are moving more into the provider space. So Humana, large payer who has done a lot of work in the Medicare Advantage space, about a year ago acquired home care and hospice assets that now make them the largest deliverer of home care and hospice in the United States. You see other entities like Partners, large player in eastern Massachusetts and beyond, moving into the payer space, either directly with Always Health or with partnerships through the Medicaid ACO and other things. So I think you'll see really interesting things at that intersection. I think right now, particularly in the Medicare space, there's a lot of interesting payer-provider partnerships. I think in the employer space, we're seeing a lot of interesting payer-provider sort of interface like Haven that's doing some interesting work, or will be. And then I think government, sort of the VA and the Medicaid space, are also opportunities nationally to do really integrated sort of full stack, meaning payer, provider, and technology.
That's great. So you really see that there's multiple people who could be these aggregators, and the financial incentives need to align to make sure that these groups are aggregating the information.
Yes, I mean, I would love to think that the moral imperative that this is the right thing to do for people is enough, and but even at times when I have worked in sort of nonprofit organizations, the adage of sort of no sort of margin, no mission. So at the end of the day, to be able to do this at scale, there has to be a model that supports it.
Great. We're gonna move on from this data discussion, but one question did come in from the audience around smartphone data, that we are looking at our smartphones 150 times a day, and that there's a tremendous opportunity to unlock that data asset. And I was wondering if folks on the panel, and Murray, I don't know if you want to start.
Sure. Yeah, I mean,
that.
Very cognizant about Julian's point that, more data is not better. I think Jean said it as well. So, understanding, one, what's the liability if I collect it, and then, what will I do with it? You have to get the signal from the noise. So, leading into the answer to that question, I just read a study on chronic heart failure patients, and they were looking at the predictive power of certain variables on readmission. It was done in Japan. They looked at 200 variables, and they literally found 6 variables that explain 90% predictive, 90% of readmission, 2 were clinical, 4 were social determinants. So it's not a lot of data, it's the right data, finding the right signal, and a lot of the effort in AI and machine learning is finding that data that's usable. Smartphone data, I would put in the category, and I love it, which is data exhaust. I do think a lot of the active tracking I'm not really a big fan of. You look at, not Fitbit in particular, but those tracking devices, lots of people, they're hugely penetrated into the adult population in the United States, but 6 months later, less than half of the people are actually using it, because it takes effort. I have to actually actively track what I'm doing. I think data exhaust, looking at something I'm doing for some other purpose already, so talk time, number of texts that I'm sending, using the GPS to see my location, which, by the way, is we're creatures of habit. We tend to follow the same path most days. So if you're off that path, could that tell me something about how you're feeling and something about your health? The accelerometer, looking at whether people are having falls or some other behavioral issues. And so there are a number of companies that are actually proven, and there have been published papers on this, where they can look just at cell phone data and they can predict depressive episodes fully 48 hours before they occur. So I'm a huge fan of being able to leverage that kind of data.
That's great. And so moving on to the next part of the story, once we have aggregated data sets and incrementally organize them, then we need to develop algorithms that help us identify patients who be amenable to these disease management programs. And we can use artificial intelligence, machine learning as part of development of algorithms. Julian and Jean, you both have been at the helms of companies that are thinking about algorithms as it helps drive your business. How are you thinking about the use of artificial intelligence and machine learning in your algorithmic development for your companies for supporting disease management?
So I think part of what's exciting here, and maybe there's a tension here between my answer around kind of the diversity and volume of data. I think part of what's exciting is to be able to think about actually adding, something like an unlimited number of variables or a much broader set of variables than we might have contemplated using kind of more traditional analytic approaches. And I think it'll be interesting to see over time how we are able to take across some of those kind of categories of data. So if you think about, a particular intervention around diabetes, and you might have looked at, 10 or 20 payer-driven metrics in the past, and a certain number of metrics from electronic health record. There may have been a remote monitoring device that's tracking your A1C. You may have used the accelerometer to track step. But when you're bringing in kind of that diverse array of data, I think you really are at a place where leveraging machine learning will be not only helpful but essential, and that's really an exciting part of the promise. And I think a lot of the disruptive companies that are here are people who are thinking about kind of opportunities at the nexus of some of those kinds of data.
Yeah, I think part of the important thing, because I hear this a lot as I speak to payers and providers, is first of all, what is ML and AI, and how should I be thinking about it? And so with respect to machine learning, I mean, increasingly the way I've come to look at it is the application of known, well-described statistical methods through typically large amounts of computing power. So it's important to be asking the questions you might have asked even 10 years ago around any statistical product that you're being shown. And when thought of that way, I say, okay, well, let's work back from the use case that we're trying to solve. And so where it's been particularly helpful to use ML is if you have a large enough data set to tease out signal from noise and be able to come up with these are the relevant factors driving a certain outcome. So the example of, in this particular condition, somebody losing access to transportation is an influencer of their risk of readmission, for example. Very helpful in that kind of a use case. And then the way I think about AI is more, where are there repetitive tasks done by human beings where a machine can either dramatically improve the efficiency or even exceed the ability of the human being to be able to deliver a certain specificity or sensitivity of result. And there, the reality is there are some narrow use cases where that works and is starting to work relatively well. So imaging and pathology are some examples. The other place is if you're an analyst and you're trying to go and find a ton of relevant outliers, either positive or negative. So for example, which of my physicians are most effective and efficient in handling a particular therapeutic condition, AI can be helpful for that. But I would call that mundane AI as opposed to fancy neural network black box AI. And the more, by the way, the AI can be unblack boxed, it's essential because ultimately you need adoption, and for adoption you need engagement, and you're only going to get engagement if people trust it. So those would be some thoughts on where we're at with ML and AI. And I think sometimes there's a ton of hype, but if you bring it back down to what's the use case and what am I trying to solve in a better way than I can do it today, then it's easier to see the forest from the trees.
Yeah, and that has been a recurring theme throughout the conference about explainability of algorithms and having transparency, which will lead to engagement.
Yeah.
One of the questions that's come through the audience, which sort of straddles data and algorithms, is natural language processing and using NLP to extract data that can help inform these algorithms. I was wondering if anyone wants to take that question on about the value. Is NLP necessary or secondary as you think about
Sure, yeah.
disease management?
Actually, it's very relevant. I started 2 companies that were at their core NLP based, and one of them was allowing medical coders to do a better job of going through patient charts for the purpose of risk adjustment. Very good use case for NLP, because the state of NLP is, up until I'm very interested in hearing nuance later because maybe it's improved, but 70-80% would be really, really good. 20% of the time, the inferences are going to be wrong, and you're going to get false positives because you're going to err on the safe side. In that use case, it doesn't matter because you're informing a coder who's very well educated, who's looking at it more like Cliff Notes. It's making recommendations, and the coder will accept 7 out of 10 of the recommendations, and they'll be able to code 2 or 3 or 5, 10 times faster. Great use case.
Right, I just realized
Yeah.
not everyone might know what I meant by NLP.
Oh,
so
natural language processing or natural language. You could speak in natural language or type in natural language, and the computer will understand and be able to take action based on that. So that use case, being able to help a coder, very good use case. Sticking it in front of a patient, in this case for disease management, if you're wrong even 10% of the time, now put yourself in the shoes of a 80-year-old patient who's chronic and just discharged from the hospital, who's scared, and now the AI is not understanding what that patient is saying. Not a very good use case. So as an example, we've chosen, even though we have a lot of AI, NLP experience, we've chosen to design Conversa to be fully structured. So it's asking questions, and then you can respond yes, no, multiple choice. We'll allow free text, but it's very constrained. And so in the back end, we're really looking for one of 50 answers. So it's NLP, but it's not open-ended. And so one, it's a very, very good experience. And you can rely on the data. So when you escalate, you have no false positives. And again, to the point you made before about narrow AI, when we think of AI, and a number of people, there's a theme here in the conference, augmented intelligence, allied intelligence, adaptive intelligence. It's being used to automate those things computers do well. Garry Kasparov, the famous chess master, said, computers make decisions. It's computational all the way down, but humans make choices. And to make the right choices, you need to know what's important and why it's important. And those things are complementary. So actually, if you look at even in pathology, there was a paper that just came out of Cornell where they took a breast cancer identification of tumors, and they compared algorithms, AI with pathologists, and the algorithms beat the pathologist. However, if you take the algorithm and then have the pathologist review it, it beats both of them hands down. It can localization, categorization of the tumor, and 85% reduction in human error. So this notion of cobots, which there are cobot chess teams now that can beat both the best computer chess players out there, I think for the foreseeable future, this notion of the right application of AI to augment or be an ally to human intelligence, allow humans to practice at the top of their license, is really the direction we're going. So full loop back to NLP, I don't think the technology is good enough to use reliably in this use case.
Yeah, and that seems to be consistent with, Jean, what you're saying. If you can't explain how that data was extracted through NLP, people lose trust. And
yeah, the example that helped me to understand the limits of NLP was a conversation with an orthopedic surgeon at UCSF 5 or 6 months ago, who said, if the natural language processing software that you, and by the way, it could be Watson, which was a great piece of NLP, right, goes to read a note and picks up at day 2 that there's redness. Okay. Well, does that mean there's an infection? Does that mean it's normal redness? Does that mean you need to go to the emergency room? And that's the point around the human beings being better able to assess context. And then one that I heard yesterday, which I thought was quite compelling as well, is even just reading through a list of symptoms in a note. Are those active symptoms, or were those not symptoms, but in the note it was referred to as not, but the computer didn't pick up the difference? So context is incredibly important, and teaching a computer how to contextualize things remains an incredibly difficult problem to solve.
Another question that came up from the audience is around digital divide and equity. So these algorithms are using existing data sets to predict who would be eligible for disease management programs. There's a presupposition that you have generated data. And if there's a digital divide, that certain communities don't have as much access to the technologies that create data, they are less likely to be engaged in disease management programs. So, and there is some evidence in care management, high-risk care management, that there is a divide, that you had to have used services, but if there's structural inequities that prevent you from using services, you won't even be identified for high-risk care management. So I want to open up to the panel just in terms of, as we think about algorithms and making sure that everyone is engaged, how do we make sure that there's equity in these algorithms that are being generated?
I think that so I've watched the kind of adoption curve on this topic shift really over the past, gosh, how long ago was it? So six, 7 years ago. So when I was running Medicaid here in Massachusetts, we had a lot of conversations around the adoption of, for example, of smartphones in our Medicaid population. I think we've seen that accelerate. There obviously not everyone has to have an iPhone to have a smartphone, so I think you're seeing greater adoption. There actually are programs in certain cases that provide sort of subsidized or even free access. I think for providers or payers, ultimately, if there is some type of technology, whether that be a smartphone or a watch or some type of remote monitoring device, if there's a true ROI for the intervention, it probably makes sense for you to give the device to the patient for free. I think it's actually a different question around whether or not the patient has the device or doesn't have the device, and around how do you build engagement and adoption. And this is one of those areas. Some of the companies, the more interesting companies around adoption that I've seen, actually up front will have a human help the person understand how to use the app, the tool, the phone, and sort of make that upfront investment, and then have just a tremendously different experience from an adoption perspective. But I think that's going to be the challenge over time. I mean, telehealth is a perfect example of this, right? So we have been waiting for the moment where telehealth is hitting, broad double-digit kind of penetration rates, and it's just taken a lot longer. But I think in places where it's not a doc in a box, but it's your primary care provider who sometimes you see in the office and sometimes you see via the phone. And when you're in the phone, either the doctor themselves or their nurse or their care manager shows you how to do it, you're going to have a different type of adoption experience. So I think we've got to think about the right ways to get people to leverage the technology even once they have it.
I'm glad that we're now talking about patient engagement, and I think this is the third chapter of the story that we wanted to tell. We've talked about data, we've talked about algorithms, and now how do we engage patients once we've identified them? So, and Erika, you said something early on, patients don't think of themselves as diseases, and so we could be coming at them with a disease management solution, but that's not how they think about themselves. So you've had a lot of experience thinking about engagement. So if you could share your experiences from both as a physician and also as building out these applications, and then I want to open up to the panel to hear everyone else's thoughts on engagement.
Sure. I mean, I think first thing starts with whether there's lots of language to talk about people, but at the end of the day, whether you're a provider working with patients or a health plan working with members, as you might call them, or a digital health company working with consumers, I think they're people living their lives trying to do and achieve what they are trying to achieve. And I think the more we can align our programs with who they are and where they are in their life, whatever that means, sort of, are they recently retired and looking to spend more time with their grandkids, and mobility in order to do that is something that they value. If that's who they are and they have care partner, a spouse, or a child who's engaged in their life. So who are they? Who is sort of the network around them? What are they trying to achieve? And then how does what I'm trying to help them with? So maybe that person I was just mentioning has very poorly controlled diabetes that is going to put them at risk for an amputation, which would impair their mobility and ability to play with their grandkids. I mean, so you have to tie sort of the disease state and both the consequences of sort of not managing that with who they are and what they're trying to do, and then given those things, what motivates them? What are their levers? So I think seeing people as people who are heterogeneous and diverse in so many ways, and meeting them where they are, and whether that's a chatbot meeting them sort of where they are and working with them to come up with a care plan that really works with them, or they're someone who, through those algorithms, was identified as particularly high risk and in need of higher touch sort of human intervention. So whether it's the digital tool or the human tool, I think we need to recognize that and design around it. I don't know if others have thoughts there.
Yeah, I mean, I couldn't agree more. We talk about putting the patients at the heart, and I already talked about it being augmented, not instead of. So we only think of the platform working with a care team. And in fact, something Julian said, to get patients, it shocks me. Telehealth is still in the employer market less than 5% adoption, but when people use it, the repeat rate is 80%, the satisfaction rate's 90%. The reason people don't use it is there's not any trusted party that's getting them to use it. So in our case, we always have a doctor, a nurse navigator, a case manager who our patients actually think of Conversa as an extension of those people. So they're enrolled in the program, and when we interview patients, they'll say, I talked to my doctor yesterday, and we'll say, do you mean you had a chat, or did you actually talk to your doctor live? And they'll say, I had the chat. So they know it's automated, but they think about it as an extension of their doctor. That gets the enrollment or the activation rates enormously high. In fact, in oncology with one of our partners, they told us it was 100%. I never believe anything that's 100%, so I went and spoke with them. And they said, no, we just say this is part of the care plan. Who's not going to listen to their oncologist? Radiation weekly. This is how we want to treat you. This is going to be good for you. So engagement is based on trust, and then activation. And then ongoing engagement, I think, is a function of meeting the patient where they are, as Erika just said. And some specifics that we talk about there are, again, not just telling the patient, we know something about you, here's what you should do, but letting the patient respond, having a conversation, and that information is going back, and in real time giving the patient value. So if we're asking for the patient's weight, we'll do a time series of their weight and show them what their weight looks like, and explain to them, if it's heart failure, maybe you're retaining too much fluid because your weight is higher, and so we recommend that you speak with somebody who will be calling you in the next 15 minutes. So it's the ability to collect information that's good for the care team, but it's providing value to the patient on an incremental basis at the point of interaction. And then it's ongoing interactions. We ask patients after every single chat, for example, not did you enjoy this, but was the chat helpful in your journey? 96% of patients say yes, and that gives us sustained engagement, which gives us permission, really, to start to move the needle on outcomes and cost. And so everything comes back to engagement. I think if you don't get engagement, you're really not going to move the needle on anything.
So as I listen to both your and Erika's discussions around how to engage patients, I might be artificially dividing this up, but there is identification of which patients need to be enrolled, and then that initial engagement, which it sounds like there's a heavy people aspect to it, and Julian, you sort of mentioned this too, making sure that people on board. But artificial intelligence, machine learning can really help with the ongoing engagement as once people are engaged in the process.
I think that's right. Yeah.
So more labor up front, but more artificial intelligence, machine learning on the back end. So what are your thoughts?
I also think there's, well, from a policy point of view and as a profession, we also need to be clear about what it is we want in terms of individual ownership over your health. Because if you bring it to the level of data, I mean, the system we have right now is crazy, because essentially what we're saying is, well, you have a bank account, but I can't tell you what you have in your bank account because the data is stuck in some other system somewhere, and you have to go get a CD to put a slice of what's in there to see what there is, right? And if we want to have individuals engaged in their health, I mean, it feels to me like the first thing should be that you should have the right to put all of your relevant data in one place. And then you would see the blossoming of a set of support services around that, because the financial analogy is people go to brokers to get advice for how to invest, and some people have now done that themselves online. But there are services that you can use, like mint.com for your credit cards or others, to give you suggestions on how you should manage your money. Well, why is it that we can't have that in healthcare? Because none of us are able to union all of our relevant data in one place. So there's also that layer of engagement in my mind, which is we have limited the engagement model to some notion of direct engagement with someone or some platform, but there's very little ability to self-direct.
It's really an important concept that you're bringing out. And a question that is adjacent to this concept that came through the audience is trust, and how do we get patients to trust the algorithms as they come out. We've talked about provider trust, but I was wondering if you guys could talk about patient trust in these disease management platforms as they become increasingly AI enabled.
So I'm not going to name the system, but I'm going to give an extreme pre-Facebook example of trust that kind of I had to kind of pick my jaw off the floor. There is a health system, a very well-known health system, academic health system, that has convinced a significant population of their patients to give them access to their social media data, all of their social media accounts. They combine that data with electronic health record data, with claims data, and will ultimately with genomics data to generate insights to drive better management of that patient population. And the patients, with the end in sight of having access to more tailored, more personalized approaches to care management and care delivery, have trusted this particular provider organization with that kind of spectrum of data. Now, this again is pre sort of some of the challenges that Facebook and some of the other companies have had around how that data is stored and leveraged, et cetera. But I think there's a version of the world where people really understand, in a world where their data is their own and they have the right to permission, who has access to it, that there are better outcomes that can be achieved when that data is in the hands of someone that they trust, and they're willing to take big steps to do that. I'm a little concerned, and I actually need to circle back with that system and see whether things have changed given some of the trust breaches that we've had. But I think if we can get to a place where people have a trusted holder of the data and a trusted actor to use the data to improve their health, there's some exciting opportunities, but maybe a little bit more cautious a walk towards that given recent developments.
Yeah, look, as long as there's a risk that you're going to lose coverage because of your health status, we're going to have a massive trust issue, period.
So one of the other, this is actually, it's a very important point, and one of the questions that came through from the audience, it's a little bit nuanced, but as we develop these disease management platforms, there's going to be the ancillary benefit that you reduce healthcare costs for everyone. But there might be people who decide to opt out from engaging in this. So they get the benefit of other people using these platforms, but they don't have to engage in these platforms. Is that, just reactions to that?
I think you have that problem today. I talk to employers all the time where healthy employees are opting out of the risk pool. You're staying on your parents' insurance plan, you're under 26, and all of a sudden you've got this skewed risk pool. And so it happens today, and I think the onus is on the provider. This is another element of engagement, because when you talked about trust, there's trust around security, there's trust around privacy, there's trust around misuse of data, there's trust around, it's not clear to me what the benefit to me is. And I think it's incumbent on anybody who's providing these services, either independently or on behalf of a provider, to clearly articulate the value. And for those that have an incentive to opt out, we need to think about the value that they're losing by opting out. And I think there are some. It's a longer conversation.
Yeah, no, I totally agree. I mean, I think it's an interesting question, but I guess I agree. Sort of the more important corollary of that is the onus is on individuals sitting in provider organizations, in payer organizations, in technology companies to build the range of tools and services that will work for everyone. And so if there is a significant cohort of individuals opting out, I think we have to spend a lot of time thinking about why are they opting out? Why is it not meeting their need? I think some of it circles back to Julian's earlier comments around sort of structural inequalities in services that people may be accessing today. It's incumbent on us to help solve that for them. So again, if it's that they don't have access to a device that we think is valuable, it's incumbent on us to think about ways to provide that device to them. I don't think about this as that different. So if people are opting out, they're probably doing so for very good reasons. And it's our job to figure out what those are and how we can better meet their needs.
Yeah, the first thing that came to mind for me was vaccination, where we say, okay, we need 80+%, if not more, of the population to be vaccinated to have herd immunity. The difference here, at least what our data scientists tell us, is that with just 7 to 10% of the Medicare data set, one can develop for most therapeutic conditions some pretty specific predictive models just off of that kind of end. So if you said, well, look, if I had 20 million, the key is to have longitudinal information so that you don't have missing holes in terms of, anyway, the predictive work that's being done. So for some things, will actually be helped tremendously just by early adopters. Now, what did the early adopters gain if what we're thinking about is allowing your de-identified data to be used for research purposes in a bigger pool? Well, you could opt in to saying that if there's a trial that's relevant to you, that you then find out about it. And that is what some health systems have done. So that there are some benefits that people who gift their data for research could get back, that obviously those that opt out won't be able to receive. But I agree with the comment that's been made that it's incumbent upon the regulatory frameworks that we put in place and how we handle the data as an industry that gives people the confidence to be able to, well, one, have it be brought together, and then two, unioned with others so that the power of it can be fully unlocked.
Great. I want to move on to provider engagement. So we've talked about how artificial intelligence and machine learning should be transparent to the clinicians who are using these disease management platforms. So we've already brought that topic out. I was wondering if the panel, if folks could also think about other areas where artificial intelligence and machine learning could help drive engagement, physician engagement in these new modalities, disease management platforms.
Sure. First, the corollary to what gets measured gets done is, what gets into workflow gets used. So I think workflow, and that's been another theme I've heard at the conference here. So, it's got to make the provider's life better. I've been increasingly, as I get into digital health, been talking about the quadruple aim being our quadruple pain, trying to get all this adoption by all the different constituents. I'll just give you one example though, because it's complicated in sort of even in a value-based world where the physicians are still fee for service. There's some payment issues that need to get worked out, but we're working with a partner, a large health system that has a centralized care management team doing care and disease management, and their protocol is, so they're dealing with a Medicare population discharged from the hospital for one of 5 different conditions or procedures, and they're making a phone call to schedule an in-home visit within 72 hours, and then they typically make between 4 and 8 calls over the remaining 30 days. That's their protocol. And it works, it's good, except it takes a lot of people and a lot of calls. And what they're looking for are those patients that are having issues and try to uncover them early. So when we started working with them and we trained the nurse navigators on this, it took a while to get them to trust it. Once they started to trust it, what happened was they would, in their words, set it and forget it. So these nurse navigators would enroll the patients after making the call and the in-home visit and the personalized enrollment. And then they told the patients understood it. This is an extension of me. It'll be checking in not 4 to 8 times, but every single day. So for 30 days, you'll have these short touch points. These chats will be collecting information, giving information back, taking readings. If there's an escalation, if we realize that there's an escalation, which is custom determined by the health system and the nurse navigators, the patient then would immediately get a call from a navigator, so they're comforted that if there's an issue, the navigator will call them. And otherwise, there's always a phone icon. They can always make a phone call. So again, it's presented as an augmented platform. And they've cut calls between, depending on the nurse navigator, between 25 and 75%. So they look at it now and say, I have all of that freed up time to spend with those patients that actually need me. So when we risk score, for example, all of these responses, it's very simple: green, yellow, red. 87% of the time, it's green. So only 17% of the time are there issues that need to get escalated or even monitored, but it's happening in 90% of the patients sometime over the 30 days. That's the problem. So you're constantly calling out to find those patients that need you. What this does is it reverses it and just has the patients or the platform doing an inbound call, raising their hand when they need to talk to a live person. So one example.
And so there's a number, we're not going to be able to get to all of the questions that are on the app. I'm going to throw out we'll go rapid fire on a number of them so we can touch on them. Do we need something like a European GDPR? Or I don't know if it's GPDR. If somebody could describe what that is, and do we need it to drive disease management platforms in American healthcare?
Yeah, so very high level. GDPR is the regulatory framework in Europe around the use of data, and what's been used in part to limit the efforts of Facebook and others to do some of the things they do. Yeah, look, it turns out that the HIPAA framework is quite sound and allows for a lot of more work to be done in this area than might be normally thought of, because essentially the HIPAA framework is, so long as what you're doing is for the improvement of patient care, and so long as you do not cross the line of using that information to do things like market directly to an individual, generally you're okay. The issue around bringing data together has a lot more to do with the behavior of certain actors in the industry. In spirit, we have lots of the elements of that in place. Now, can they be improved? Absolutely. I thought the talk yesterday by Secretary Verma touched on many of the relevant points that still need to be addressed on that front.
Yeah. And sort of adjacent to that is another question of, should we have a trusted holder of all data, or why not use technologies like blockchain to help support our work in disease management, artificial intelligence? Do folks have thoughts on that?
So I don't think that we're going to get to a place in this country where we have a single trusted holder of all data for a whole host of reasons that I won't kind of take us down that path right now. I think that there is some potential for blockchain, and it's happening, right? So you're seeing these kind of big payer collaboratives, for example, around specific uses of blockchain. I don't know that blockchain will solve all of our ails around this issue, but I think we're going to have kind of a range of solutions targeted at specific problems, and they will vary kind of across the healthcare ecosystem, but there's not going to be, I don't think that there's a single silver bullet, and that our kind of political and economic context would tolerate a single trusted holder and source.
And just as a final capstone question, so we've talked a lot about artificial intelligence and machine learning and how it'll play a role in terms of data aggregation, algorithms, patient engagement, provider engagement. We have a slew of failed experiments in disease management, but yet this panel is ever the optimistic panel. And so I want to ask you all to just tell me a little bit about where you think there will be success in disease management, especially artificial intelligence and machine learning empowered disease management. Erika, you want to start?
Yeah, so hopefully we've learned from our mistakes. But I think as we've sort of referenced throughout the panel, I think there's been tremendous progress in breakdown of data silos, so multiple players having access to diverse data sources, improved ability to build meaningful algorithms that help you to identify the right patient at the right time for the right intervention that will actually work for them in their life. And I think that's a fundamentally different space than we were sort of even 5 and 10 years ago. I think it's a very different conversation. So I remain very optimistic that with those diverse data sets used by sort of provider entities that are fully aligned with achieving the best outcomes for their patients will be successful.
So I think probably 3 areas. So we've talked a lot about kind of further optimization of stratification models. A second is better refinement of workflow around specific kind of provider use cases. And then I think a third is really what I'll call sort of personalized disease management. And I think there have been a number of things that touch on this, but how do you kind of understand at a more micro level the things that could impact the disease state for a specific patient and the things that you can actually intervene upon? Those are the 3 areas that I think are the most exciting.
Yeah, I think that last point, I was fascinated by the discussion yesterday. I think it was yesterday with the head of the American Heart Association and the head of the NHS, who sort of had very diametrically opposed views of guidelines in the future. And I definitely thought they both made good points, but I think it's a timing issue, and I think the NHS head was talking about the future, one, we won't have guidelines and we shouldn't aspire to not have guidelines. And I agree with that. You can't get to personalized healthcare without that, and recognizing that you have to treat an individual person and the whole person. And so I think we're going to see a lot of progress in doing that. I think the data issues that we all talked about, and everybody talks about security and privacy and misuse, I think those are the small issues. I think the bigger issues is how do we validate the real world evidence data so we actually can have personalized and precision health, not just in medicine, but healthcare broadly. How do you validate the stuff that's out there in the wild, right? EMR data is not validated for this kind of a use. So I think that's one issue that we'll have to overcome. I think there'll be exciting new opportunities for people to solve that problem. And then in specific areas, I think, with 100 million diabetic, pre-diabetic folks in this country, I think, and there's a lot of effort and investment going into that space, I think that's probably the biggest first success that we'll see, probably followed by heart-related conditions. And I would say those would be the top 2. And the reason I say that is back to my first point around what are the things that are in the patient's control to affect. And I think those 2 in particular are driven more by behavior. They index higher on the behavior scale than the others do. And so I think these ongoing frequent touch points, whether it's with a conversational or other type of platform, but really putting the patients at the heart. We have a lot of people who talk about, at this conference too, putting patients at the heart means getting them education. I'll go one step further, education that's actionable. I don't think any of that is enough. It needs to be something that, not that's just actionable, but they take action. And so there needs to be this frequent, constant, listening to the patient voice.
Yeah, and so I'm very bullish about where this can go, because I don't think we're very far from this kind of insight being available in the workflow, even if it's through the EMR. The one thing I'd note that we've talked about less today, where I do think this can have a big impact as well, is end of life, and making sure that individuals have the right plans, personalized plans in place for that, and the right intervention match for them.
None of you talked about the post-surgical or bundles or procedural areas. Is that an opportunity as well, or is it more in the chronic disease or end-of-life discussions that you're seeing the opportunity?
We actually started there. I'm sorry. We actually started with post-acute, followed quickly by pre and post-surgical. So we have bundles around hip and knee, and now we're doing bariatric surgery and urology and a number of others. So. I think of those as acute incidences of disease management, so I didn't spend a lot of time on it. But I think it's a big opportunity there.
Yeah, I totally agree. I think perhaps in other arenas it's more common to think of disease management as chronic disease management, but would agree it runs the full gamut of life, sort of whatever conditions are affecting that individual at that time. And and totally agree. For these interventions to be effective, it has to be married to what is a reasonable goal or outcome for that patient. So we can't cure disease in all cases. I think these same sets of tools and ideas are just as applicable in end-of-life setting as they are when our goal is primary prevention or secondary prevention.
Well, I want to thank the panel and thank you all for joining us for a great discussion around disease management.
Okay, great, thank you.